It may seem as though the Syrian refugee crisis is both a thing of the past, but also a dilemma that is far, far away from the United States. Neither of these is true, of course, and this presentation is intended not only to remind audiences of its continuing trauma and heartbreak, but also of its relationship to U.S. healthcare matters. The needs of those who have been forced to relocate are not solved simply by arriving in America, and their medical as well as mental health care must remain a conscious, active consideration by policymakers and clinical providers. When the crisis first began over 7 years ago, it hit what the West would consider a middle-class, modern society. Syria was a thriving country of educated and sophisticated people, the worldly descendants of one of the world's first recognized civilizations. Of the millions who have since scattered in the 21st century diaspora, only a small percentage have made it to the United States. Yet regardless of its size, this population still has acute health care and mental health needs, particularly for the women and children among them. Vaginitis, urinary infections and incontinence, dysmenorrhea, and poor pre- and post-natal care were common among the female patients. PTSD, depression, and particularly separation anxiety among the children. Adding to these challenges are some of the cultural issues that emerge, as they would from any country, when managing the health care of a displaced people. For instance, much of Syrian society was uncomfortable with publicly acknowledging the need for mental health services or their efficacy. And despite its developed industrial, medical, commercial, and finance sectors, the tradition of forced or early marriage for young women remained a presence in the pre-war society. Finally, Syria had been a refuge for other displaced people prior to their own war. So those who have subsequently fled may either not neatly identify with Syrian identity or have their own history with trauma and such displacement. A handful of organizations in the US have sprung up to help with the healthcare crisis of this population, such as the Philadelphia Refuge Health Collaborative and Washington State Northwest Immigrant and Refugee Health Coalition, formerly known as the New Arrivals Working Group. Still others have gone to the source of the matter, looking to aid Syrian refugees in camps or centers ahead of permanent relocation. Federal efforts, however, have been rather negligible, with the Office of Refugee Settlement experiencing both considerable cutbacks and delays in new service. So, what is to be done? First, there is the immediate potential to upscale efforts like those begun in Pennsylvania and Washington, even if decreased effort is being exerted by Pennsylvania Avenue in Washington, D.C. Second, enduring charitable gifts and donations should be promised and delivered to nonprofit organizations so that their medical and mental health budgets can be set reliably and without immense fluctuation, particularly downward. Finally, a new public pressure effort should be developed to lobby U.S. politicians into better embracing these refugees on our shores. Americans may be generous and loving, but the federal government has not reflected this in its concern for refugees worldwide or on its soil. Only expansion, not retraction or dismissal, of these efforts will have any effect on refugee outcomes. This is not a problem to postpone, to table until some more convenient time. People are hurting now, and the more time that passes, the deeper these wounds set. Thank you.